Assalamualaikum warahmatullahi wabarakatuh. Pada kesempatan perkuliahan online kali ini kita akan membahas tentang penyakit diabetes mellitus. Sebelumnya nanti akan ada kuis atau ada tugas yang harus dikerjakan oleh mahasiswa. Bisa nanti di-upload di Skalsa atau dikumpulkan di meja saya. Kita mulai. Untuk diabetes mellitus. Apa itu diabetes mellitus? Kalau kita lihat sering terjadi dan akan terus meningkat setiap tahunnya, karena memang penyakit ini lebih banyak atau lebih besar diakibatkan oleh gaya hidup atau lifestyle, atau bagaimana manusia itu makan kemudian beraktivitas. Kita mulai. Sudah banyak definisi dari beberapa referensi apa yang dimaksud dengan diabetes mellitus. Ada beberapa yang menyebutkan diabetes mellitus adalah ketika seseorang mengalami hiperglikemi. Kita lihat dari definisi yang pertama, diabetes mellitus adalah sekelompok penyakit yang ditandai dengan tingginya kadar glukosa darah atau hiperglikemi yang diakibatkan oleh kerusakan dalam produksi insulin atau aksi insulin atau keduanya. Jadi kalau kita lihat di beberapa referensi hanya menyebutkan tingginya kadar glukosa, tetapi di sini ada tambahan bahwa terjadi kerusakan insulin atau sekresi insulin. Tetapi tidak hanya sekresi yang mungkin terjadi, bisa jadi karena adanya aksi insulin yang terganggu. Ini yang nanti bisa sebagai pembeda antara DM tipe 1 dengan DM tipe 2. Istilah yang lain menggambarkan gangguan metabolisme dengan berbagai etiologi ditandai dengan hiperglikemi kronis, dengan gangguan metabolisme karbohidrat, lemak, protein akibat defek atau kekurangan sekresi insulin, aksi insulin atau keduanya. Dan efek diabetes mellitus termasuk kerusakan jangka panjang dan bisa mengakibatkan komplikasi seperti kegagalan berbagai organ dan disfungsi. Diabetes mellitus dapat muncul dengan gejala yang khas. Saya kira sudah banyak yang tahu, ya, terutama orang ingin minum terus-menerus, ingin makan terus-menerus, atau orang ingin buang air kecil terus-menerus. Selain itu juga pandangan menjadi kabur dan penurunan berat badan. Tanda dan gejala yang paling parah seperti ketoasidosis atau gejala hiperosmolar non-ketotik yang biasanya bisa berkembang dan mengarah pada keadaan stupor, bahkan bisa sampai mengalami koma dan kematian. Seringkali gejalanya pada awalnya tidak parah, mungkin tidak tahu ya kalau orang tersebut mengalami DM, ya, akibat dari hiperglikemi menyebabkan perubahan patologis dan fungsi pada organ tubuh, sehingga itu sudah muncul dalam waktu yang lama sebelum diagnosa ditegakkan. Kemudian selanjutnya adalah terkait dengan efek jangka panjang dari diabetes mellitus, termasuk perkembangan yang progresif. Jadi semakin parah dari komplikasinya, seperti retinopati, dari mulai penglihatan kabur sampai terjadi kematian pada retina, sehingga berpotensi kepada kebutaan. Dan ada juga selain dari retinopati, nefropati atau kerusakan pada ginjal, atau ginjal mengalami kegagalan atau gagal ginjal. Yang lain adalah neuropathy, terjadi kematian pada saraf, terutama pada saraf ekstremitas. Jadi sehingga beresiko terjadi ulkus pada kaki. Lanjut. Yang lain adalah terjadi gangguan persendian, mungkin bisa sampai nyeri di persendian dan disfungsi seksual. Penderita diabetes mellitus beresiko tinggi terkena penyakit kardiovaskuler, vaskuler peripheral dan cerebrovaskuler. Ya, kita lihat bagaimana komplikasi perjalanan atau mekanisme komplikasi diabetes mellitus. Perkembangan diabetes diprediksi mencapai proporsi pandemi selama 10-20 tahun ke depan. Ya, dari IDF mengindikasikan pada tahun 2025 jumlah orang yang terkena dampak bisa mencapai 333 juta dan 90%-nya orang-orang yang menderita diabetes mellitus adalah tipe 2 dan 10%-nya adalah tipe 1. Biaya kesehatan tahunan yang disebabkan oleh diabetes mellitus dan komplikasinya bisa mencapai sekitar 6-12% dari seluruh pengeluaran perawatan kesehatan. Untuk tipe-tipe dari diabetes, tipe yang pertama dari pengertian yang lain itu DM yang tergantung insulin. Yang kedua, tipe 2, DM yang tidak tergantung insulin. Yang ketiga, diabetes gestasional atau diabetes ketika hamil. Dan beberapa tipe yang lain. Ya, tugas pertama untuk mahasiswa nanti silahkan mencari apa itu LADA atau Latent Autoimmune Diabetes in Adults. Yang kedua, mencari tentang MODY atau Maturity Onset Diabetes of Youth atau of Young. Jadi silakan tugas yang pertama untuk mencari LADA dan MODY. Nanti bisa di-upload di Skalsa atau bisa juga nanti ditaruh di meja saya. Selanjutnya DM tipe 1. DM tipe 1 sebelumnya disebut Insulin Dependent Diabetes Mellitus atau IDDM. Jadi pasien tersebut tergantung dengan insulin. Dan DM tipe 1 berkembang ketika sistem imun tubuh merusak sel beta pankreas, satu-satunya sel di dalam tubuh yang memproduksi hormon insulin, yang fungsinya adalah secara sederhana mengatur glukosa darah. Tapi nanti kita lihat bagaimana fungsi dari hormon insulin. Diabetes ini biasanya menyerang pada anak-anak dan dewasa muda. Nah, walaupun banyak juga yang terkena pada umur-umur yang lain. Dan biasanya mencapai 5-10% dari semua kasus diabetes yang didiagnosa. Tadi sekitar 90% untuk DM tipe 2, yang 10%-nya kebanyakan DM tipe 1. Faktor resiko untuk diabetes mellitus tipe 1 mungkin termasuk dari faktor autoimunnya. Jadi sistem antibodi menyerang dari pankreas atau merusak sel pankreas, terutama sel beta pankreas. Selain karena faktor autoimun, juga faktor genetik dan faktor lingkungan. DM tipe 2 sebelumnya disebut non-insulin dependent diabetes mellitus, yaitu tipe diabetes yang terjadi pada seseorang tetapi orang tersebut tidak tergantung insulin. Bisa jadi produksi insulinnya menurun atau normal. Akan tetapi DM tipe 2 ini insulinnya tidak bisa dipakai. Jadi yang membedakan DM tipe 1 dan DM tipe 2, DM tipe 1 biasanya terjadi produksi insulin di pankreas yang berkurang, sehingga ketika disekresikan ke tubuh juga berkurang, bahkan bisa sampai tidak memproduksi insulin. Sedangkan DM tipe 2 tetap ada produksi insulin, bisa jadi normal, tetapi tidak bisa dipakai. Jadi ini terkait dengan aksi insulin. Kalau DM tipe 1 terkait dengan sekresi insulin, kalau DM tipe 2 terkait dengan aksi insulin. Kalau kita lihat dari DM tipe 1, untuk DM tipe 1 ini insulin jumlahnya tidak mencukupi, sehingga banyak glukosa yang tidak bisa masuk ke dalam sel. Sedangkan DM tipe 2, kadar insulin ketika normal jumlahnya cukup untuk menuju ke sel, sebagai kunci untuk membuka supaya glukosa masuk ke sel. Akan tetapi aksinya ini yang terganggu. Jadi bisa jadi gangguannya ada pada reseptor insulin, atau bisa jadi gangguannya ada pada insulin yang diproduksi. Yang pertama, bisa jadi reseptor insulin yang berada di sel ini mengalami kerusakan, sehingga resisten terhadap insulin. Sedangkan kemungkinan yang kedua adalah insulinnya sendiri. Reseptor insulin mungkin normal, akan tetapi insulin yang diproduksi oleh beta pankreas mengalami kecacatan, sehingga ketika bertemu dengan reseptor insulin maka terjadi resistensi. Jadi kemungkinan karena kerusakan atau kecacatan pada reseptor insulin, atau yang kedua kecacatan atau kerusakan pada insulinnya sendiri. Ini yang membedakan. Nah, ketika kebutuhan insulinnya meningkat, sehingga lama-kelamaan pankreas secara bertahap kehilangan kemampuan, karena insulin itu tidak bisa digunakan, sehingga beta pankreas akan berusaha melakukan atau memproduksi insulin kembali, dan lama-kelamaan akan kehilangan kemampuan untuk memproduksi insulin. Nah, ini dikaitkan dengan usia yang lebih tua, obesitas, riwayat diabetes keluarga, riwayat diabetes gestasional, gangguan metabolisme glukosa, kurang aktivitas, dan ras atau etnik. Nah, di sini kalau kita lihat sekarang tidak hanya pada orang dewasa saja, tetapi DM tipe 2 ini juga banyak didiagnosa pada anak-anak atau remaja. Nah, ini kalau kita lihat gambarnya terkait dengan DM tipe 1 dan DM tipe 2. Nah, kalau misalkan DM tipe 1 karena jumlah insulinnya yang sangat berkurang, sehingga glukosa hanya masuk ke sebagian sel di dalam tubuh. Sedangkan DM tipe 2 di sini insulin bisa jadi cukup, tetapi tidak bisa dipakai, sehingga aksinya untuk berikatan dengan reseptor insulin tidak terjadi. Ini yang menjadi permasalahan untuk DM tipe 1 dan DM tipe 2. Akan tetapi tidak semua sel itu memiliki reseptor insulin. Salah satunya ada otak. Otak ini adalah satu-satunya organ yang tidak membutuhkan insulin, karena di otak ini tidak ada reseptor insulin, sehingga glukosa bisa langsung masuk ke dalam jaringan otak. Di sisi lain, otak ini hanya bisa menggunakan glukosa, tidak bisa menggunakan protein dan lemak untuk dijadikan energi. Yang perlu digarisbawahi untuk dijadikan energi, karena jaringan protein atau lemak itu tetap dibutuhkan oleh otak. Salah satunya untuk protein, untuk sintesis protein, untuk regenerasi sel. Tetapi tidak bisa dipakai untuk menghasilkan energi, dan energi ini hanya bisa didapatkan oleh glukosa. Nah, ini aksi dari insulin, ya, dari prosesnya terkait dengan glukosa yang tinggi di dalam darah, bagaimana supaya dalam keadaan seimbang atau dalam batas-batas homeostasis, keseimbangan di dalam tubuh untuk glukosa. Kalau misalkan terlalu tinggi, maka dia akan diturunkan dengan cara memproduksi insulin. Ya, insulin ini nanti bisa membuat glukosa yang ada di dalam darah menuju ke sel. Ada yang digunakan sebagai energi, ada yang disimpan seperti di sel adiposa, di liver atau di hati. Selanjutnya yang berikutnya adalah diabetes gestasional. Diabetes gestasional ini bentuk intoleran terhadap glukosa yang didiagnosis pada beberapa ibu selama kehamilan. Ini lebih umum di antara wanita gemuk dan wanita dengan riwayat keluarga diabetes. Jadi lebih banyak terjadi untuk prevalensinya pada wanita yang gemuk dan wanita dengan riwayat keluarga yang mengalami DM. Selama kehamilan, DM gestasional ini memerlukan perawatan untuk menormalkan kadar glukosa darah untuk menghindari komplikasi pada bayi. Setelah kehamilan pun sekitar 5-10% wanita dengan diabetes gestasional ditemukan menderita DM tipe 2. Jadi setelah kehamilan ada beberapa yang kena DM tipe 2. Wanita yang memiliki diabetes gestasional memiliki peluang 20% hingga 50% untuk terserang DM dalam 5 tahun sampai 10 tahun ke depan. Jadi kalau sudah kena diabetes gestasional, kemungkinannya sekitar 20%-nya dalam jangka waktu 5 sampai 10 tahun bisa kena DM tipe 2. Yang lain adalah jenis-jenis diabetes spesifik lainnya dihasilkan dari kondisi genetik spesifik, seperti karena usia muda, pembedahan, obat-obatan, kekurangan gizi, infeksi, dan lain sebagainya. Bisa jadi DM-nya ini karena adanya infeksi terlebih dahulu, atau sebelumnya karena ada efek dari obat-obatan. Dan jenis diabetes ini bisa mencapai 1-5% dari semua kasus. Penyebab sekunder dari diabetes mellitus meliputi ada akromegali, sindrom Cushing, ada thyrotoxicosis, ada pancreatitis kronis, kanker, hiperglikemi yang diinduksi oleh obat seperti ada antipsikotik, atipikal, ada beta blocker, dan lain sebagainya. Sebagai contoh, untuk antipsikotik atipikal ini akan menyebabkan peningkatan resistensi insulin, sedangkan beta blocker menghambat sekresi insulin. Calcium channel blockers ini menghambat sekresi insulin. Kortikosteroid menyebabkan resistensi insulin, dan beberapa obat yang lain yang di sini berperan penting di dalam menghambat sekresi insulin atau meningkatkan resistensi insulin. Kemudian kalau kita lihat, apakah setiap orang yang mengalami peningkatan kadar glukosa atau hiperglikemi pasti mengalami DM? Jawabannya tidak. Tergantung seberapa kadar glukosa darahnya. Nah, kalau selama ini kita lihat, kalau orang yang sudah di atas 200 dia masuk diabetes mellitus. Bagaimana kalau yang kurang dari itu tetapi sudah tidak normal? Maka bisa kita sebut sebagai prediabetes. Prediabetes adalah istilah yang digunakan untuk membedakan orang yang berisiko tinggi terkena DM, dan penderita prediabetes ini mengalami gangguan glukosa puasa atau toleransi glukosa yang terganggu. Atau beberapa orang bisa kena kedua-duanya. Gangguan glukosa puasa ini biasanya meningkat untuk kadar glukosanya 100 hingga 125 mg per dl. Tapi tidak cukup tinggi untuk dikatakan diabetes. Nah, kemudian toleransi glukosa yang terganggu. Ya, ini kondisi di mana kadar glukosanya kurang dari 200, sekitar 140 hingga 199 mg per dl setelah tes toleransi glukosa oral 2 jam. Jadi setelah makan ya langsung 2 jam kemudian dites, atau kalau bahasa yang sering digunakan adalah GDS, gula darah sewaktu, itu kurang dari 200 tetapi lebih dari 140. Nah, itu masuk ke prediabetes. Perubahan menjadi diabetes ini bisa sangat mungkin terjadi. Nah, dan ternyata dari beberapa penelitian atau studi menunjukkan bahwa penurunan berat badan, peningkatan aktivitas fisik ini bisa mencegah terjadinya prediabetes, karena memang sangat beresiko, atau orang tersebut lebih beresiko mengalami DM ketika dia sudah prediabetes, sehingga perlu adanya pola hidup seperti aktivitas fisik untuk mengurangi resiko diabetes. Dan orang yang mengalami prediabetes ini juga beresiko terjadi penyakit stroke dan jantung. Bagaimana diagnosis dari diabetes mellitus? Ini untuk tabelnya, bagaimana ketika dia puasa dan 2 jam setelah dia makan, atau orang yang diperiksa GDS-nya. Pencegahan. Ya, nanti sebelum ke pencegahan saya perlihatkan bagaimana komplikasi dari diabetes mellitus.
Diabetes mellitus, your body has trouble moving glucose, which is a type of sugar, from your blood into your cells. This leads to high levels of glucose in your blood and not enough of it in your cells. And remember that your cells need glucose as a source of energy. So not letting the glucose enter means that the cells starve for energy despite having glucose right on their doorstep. In general, the body controls how much glucose is in the blood relative to how much gets into the cells with 2 hormones, insulin and glucagon. Insulin is used to reduce blood glucose levels, and glucagon is used to increase blood glucose levels. Both of these hormones are produced by clusters of cells in the pancreas called islets of Langerhans. Insulin is secreted by the beta cells in the center of the islets, and glucagon is secreted by alpha cells in the periphery of the islets. Insulin reduces the amount of glucose in the blood by binding to insulin receptors embedded in the cell membrane of various insulin-responsive tissues like muscle cells and adipose tissue. When activated, the insulin receptors cause vesicles containing glucose transporter that are inside the cell to fuse with the cell membrane, allowing glucose to be transported into the cell. Glucagon does exactly the opposite. It raises the blood glucose levels by getting the liver to generate new molecules of glucose from other molecules, and also break down glycogen into glucose so that it can all get dumped into the blood. Diabetes mellitus is diagnosed when blood glucose levels get too high, and this is seen among 10% of the world population. There are 2 types of diabetes, type 1 and type 2, and the main difference between them is the underlying mechanism that causes blood glucose levels to rise. About 10% of people with diabetes have type 1, and the remaining 90% of people have type 2. So let's start with type 1 diabetes mellitus, sometimes just called type 1 diabetes. In this situation, the body doesn't make enough insulin. The reason this happens is that in type 1 diabetes, there's a type 4 hypersensitivity response, or a cell-mediated immune response, where a person's own T cells attack the pancreas. As a quick review, remember that the immune system has T cells that react to all sorts of antigens, which are usually small peptides, polysaccharides, or lipids, and that some of these antigens are part of our own body's cells. It doesn't make a lot of sense to allow T cells that attack our own cells to hang around. And so there's this process to get rid of them called self-tolerance. With type 1 diabetes, a genetic abnormality causes a loss of self-tolerance among T cells that specifically target the beta cell antigens. Losing self-tolerance means that these T cells are allowed to recruit other immune cells and coordinate an attack on these beta cells. Losing beta cells means less insulin, and less insulin means that glucose piles up in the blood because it can't enter the body's cells. One really important set of genes involved in the regulation of the immune response is the human leukocyte antigen system, or HLA system. Although it's called a system, it's basically this group of genes on chromosome 6 that encode the major histocompatibility complex, or MHC, which is a protein that's extremely important in helping the immune system recognize foreign molecules, as well as maintaining self-tolerance. MHC is like the serving platter that antigens are presented to immune cells. Interestingly, people with type 1 diabetes often have specific HLA genes in common with each other, one called HLA-DR3 and another called HLA-DR4. But this is just a genetic clue, right? Because not everyone with HLA-DR3 and HLA-DR4 develops diabetes. In diabetes mellitus type 1, destruction of beta cells usually starts early on in life, but sometimes up to 90% of the beta cells are destroyed before symptoms crop up. 4 clinical symptoms of uncontrolled diabetes that all sound similar are polyphagia, glycosuria, polyuria, and polydipsia. Let's go through them one by one. Even though there's a lot of glucose in the blood, it can't get into the cells, which leaves cells starved for energy. So in response, adipose tissue starts breaking down fat, called lipolysis, and muscle tissue starts breaking down proteins, both of which result in weight loss for someone with uncontrolled diabetes. This catabolic state leaves people feeling hungry, also known as polyphagia. Phagia means eating, and poly means a lot. Now, with high glucose levels, that means that when blood gets filtered through the kidneys, some of it starts to spill into the urine, called glycosuria. Glycose refers to glucose, and urea refers to the urine. Since glucose is osmotically active, water tends to follow it, resulting in an increase in urination, or polyuria. Poly again refers to a lot, and urea again refers to urine. Finally, because there's so much urination, people with uncontrolled diabetes become dehydrated and thirsty, or polydipsia. Poly means a lot, and dipsia means thirst. Even though people with diabetes aren't able to produce their own insulin, they can still respond to insulin. So treatment involves lifelong insulin therapy to regulate their blood glucose levels, and basically enable their cells to use glucose. One really serious complication with type 1 diabetes is called Diabetic Ketoacidosis, or DKA. To understand it, let's go back to the process of lipolysis, where fat's broken down into free fatty acids. After that happens, the liver turns the fatty acids into ketone bodies, like acetoacetic acid and beta-hydroxybutyric acid. Acetoacetic acid is a keto acid because it has a ketone group and a carboxylic acid group. Beta-hydroxybutyric acid, on the other hand, even though it's still one of the ketone bodies, isn't technically a keto acid since its ketone group has been reduced to a hydroxyl group. These ketone bodies are important because they can be used by cells for energy. But they also increase the acidity of the blood, which is why it's called ketoacidosis. The blood becoming really acidic can have major effects throughout the body. Patients can develop cosmal respiration, which is deep and labored breathing as the body tries to move carbon dioxide out of the blood, in an effort to reduce its acidity. Cells also have a transporter that exchanges hydrogen ions, or protons, H+, for potassium. When the blood gets acidic, It's by definition loaded with protons that get sent into the cells while potassium gets sent into the fluid outside the cells. Another thing to keep in mind is that in addition to helping glucose enter cells, insulin stimulates the sodium-potassium ATPases, which help potassium get into cells. And so without insulin, more potassium stays in the fluid outside the cells. Both of these mechanisms lead to increased potassium in the fluid outside the cells, which quickly makes it into the blood and causes hyperkalemia. The potassium is then excreted, so over time, even though the blood potassium levels remain high, overall stores of potassium in the body, which includes potassium inside cells, starts to run low. Patients will also have a high anion gap, which reflects a large difference in the unmeasured negative and positive ions in the serum, largely due to this buildup of keto acids. Diabetic ketoacidosis can happen even in people who have already been diagnosed with diabetes and currently have some sort of insulin therapy. In states of stress, like an infection, the body releases epinephrine, which in turn stimulates the release of glucagon. Too much glucagon can tip the delicate hormonal balance of glucagon and insulin in favor of elevating blood sugars, and can lead to the cascade of events we just described: increased glucose in the blood, loss of glucose in the urine, loss of water, dehydration, and in parallel a need for alternate energy, generation of ketone bodies, and ketoacidosis. Interestingly, both ketone bodies break down into acetone and escape as a gas by getting breathed out the lungs, which gives a sweet, fruity smell to a person's breath. In general, though, that's the only sweet thing about this illness, which also causes nausea, vomiting, and, if severe enough, mental status changes and acute cerebral edema. Treatment of a DKA episode involves giving plenty of fluids, which helps with dehydration, insulin, which helps lower blood glucose levels, and replacement of electrolytes like potassium, all of which help to reverse the acidosis.
Diabetes mellitus 2, or diabetes type 2. Diabetes type 2 is a progressive disorder defined by deficits in insulin secretion and action. What I mean by deficit insulin action is insulin resistance. For example, here we have a blood vessel and here a cell with an insulin receptor. In diabetes type 2, we have a decrease in insulin in the plasma and also insulin resistance, where the effect of insulin on the cell does not take place. As a result of a decrease in insulin secretion and insulin resistance, we get hyperglycemia, or high blood glucose. Persistent high blood glucose results in diabetes. Before we delve into the signs and symptoms and the pathophys of diabetes, let us learn a bit more about insulin. Let us zoom into this area of the abdomen where we can find the pancreas. The pancreas is tucked under the stomach and connects to the small intestine. The pancreas contains glands and ducts. Let us zoom into this area of the pancreas. Here I'm drawing the pancreatic ducts and glands. These clusters here are known as Pancreatic Isana. These asana contains exocrine cells, which release enzymes for digestion, which then go essentially to the small intestine. Around the pancreatic isana are clusters of cells known as islets of Langerhans. These cells are endocrine cells. It is from these cells where the hormone insulin is secreted into the blood. Insulin is an important hormone that has many effects on our body. The main site insulin target are skeletal muscles, liver, and adipose tissue or fat. In general, the main function of insulin is to store energy. In skeletal muscle and adipose tissue, insulin increases glucose uptake and glycolysis for energy storage. Insulin has a big effect on the liver, including increasing glycolysis, increasing protein synthesis, increasing lipogenesis. Insulin also decreases gluconeogenesis, lipolysis, glycogenolysis, and protein breakdown. All in all, insulin promotes glucose uptake and energy storage, and inhibits the release of glucose to blood. Let us take a closer look at the islets of Langerhans, where insulin is produced. So here are the Isana cells, which are your exocrine cells. Next to them, we have islets of Langerhans, which are the cluster of endocrine cells which produce hormones. The majority of endocrine cells within one islet of Langerhans are beta cells, which are the cells that actually produce insulin as well as amylin. There are also other cells here, the alpha cells, which produce glucagon, and delta cells, which produce somatostatin. It is important to know that glucagon is another hormone that does essentially the opposite function of insulin. Now let us learn a bit more about how and when beta cells release insulin into the blood. So here I am drawing a beta cell of the pancreas. The cell contains mitochondria, and on the cell membrane we find many channels, including GLUT2, not 4, a GLUT2, a calcium voltage gated channel, and potassium passive channel. So let us look at the steps involved in insulin secretion by the beta cells. After a meal, there is an increase in blood glucose. An increase in blood glucose results in glucose entering the beta cells through the GLUT2 transporter. The glucose in the cell is then metabolized through glycolysis and Krebs cycle in the cytoplasm and the mitochondria, producing many ATP. ATP is energy. Normally in the beta cell, potassium flows out, creating a negative gradient within the cell. However, the increase in ATP actually inhibits this process. So step 4, increase in ATP triggers depolarization cascade within the cell, resulting in insulin release. So drawing it out, the increase in cellular potassium causes depolarization, resulting in opening of calcium voltage gated channels. This causes an influx of positively charged calcium. The calcium then triggers insulin release via the vesicles. When insulin is secreted into the blood, it then targets cells and binds to the insulin cell receptor, telling the cell to increase the uptake of glucose and to store it. This is a normal process and results in a decrease in blood glucose level. However, in diabetes type 2, this whole process gets messy. In diabetes, you do not have enough insulin secretion and you develop insulin resistance as a result. This results in blood glucose staying high. Persistent high blood glucose results in the clinical manifestations we see in a patient who has diabetes. A person with diabetes can be asymptomatic for some time, but common signs and symptoms include infections, regular infections, fatigue, blurred vision, and the 4 Ps: paresthesia, polydipsia, polyuria, and polyphagia. The risk factors for diabetes include older age, obese, having a family history, having other cardiovascular disease risk factors, gestational diabetes, and polycystic ovarian syndrome. So we learned about the signs and symptoms and the risk factors for diabetes. But what happens when diabetes progresses and is untreated? As diabetes progresses, is undiagnosed or untreated, several complications can actually occur. These can be divided into microvascular and macrovascular complications. So microvascular complications include retinopathy, neuropathy, and nephropathy. Macrovascular complications include coronary heart complications, cerebrovascular complications, and peripheral vascular complications. Let's focus on microvascular complications, beginning with retinopathy. The eyes of a person with diabetes should be examined regularly. Internal changes such as cotton wool spots, microhemorrhages, microaneurysms, and macular thickening may occur. Eye conditions such as glaucoma and cataracts may result. Neuropathy complications can be divided into peripheral and autonomic neuropathy. Peripheral neuropathy includes a decrease or increase in pain sensation, painless injuries, and decrease in reflex. Autonomic neuropathy include resting tachycardia, urinary frequency, and erectile dysfunction in men. Nephropathy complications include glomerulosclerosis and pyelonephritis. Pyelonephritis is infection of the kidney. So that was microvascular complications due to diabetes. Now we are looking at the macrovascular complications, which include coronary heart complications. And this can be chest pain, congestive heart failure, and dyspnea. Cerebrovascular complications can result in hemorrhages, cerebral infarcts, and memory problems. Peripheral vascular disease complications include atherosclerosis, gangrene, and ulcerations. It is very important to have regular foot checks in a patient with diabetes, as loss of sensation together with a compromised vascular supply can lead to some serious problems in the peripheral tissue. So here is a foot. If you have atherosclerosis occurring, gangrene can occur, infections can occur, and at times amputations are necessary. Ulcerations can also occur in the foot of a person without the person knowing it. Common sites are on the sole of the foot, commonly around where most of the pressure is exerted. Now we are going to look at the pathophysiology of these complications that occur in diabetes. And in order to understand this, we have to look at the vascular changes that occurs. These vascular changes are essentially what leads to the microvascular and macrovascular changes we see in diabetes. Three things happen in the vessels of patients with diabetes. Atherosclerosis, arteriosclerosis, and inflammation. Atherosclerosis, remember, is the plaque buildup in the vessel. The alteration in vascular homeostasis due to endothelial and smooth muscle cell dysfunction are the main features of diabetic vasculopathy. Okay, let us zoom into the layer of the vessel. This is the lumen, endothelium, tunica intima, and tunica media. Tunica media is where the smooth muscle layer is. Within the lumen, we have red blood cells and other proteins. This is also where glucose, travels. In diabetes, we have high blood glucose. When there is high blood glucose, the endothelial cells will eventually take most of it up. The interesting thing here is that the endothelial cells of the vessels do not need insulin to take up glucose. It just does it. With so much glucose being taken inside the endothelial cells, the cells produce a lot of energy, and as a byproduct, reactive oxygen species, or ROS. The increase in reactive oxygen species, ROS, leads to a number of things. One, formation of advanced glycosylated protein products. Reactive oxygen species stimulates protein kinase C activity, which sort of forms a continuous stimulatory cycle. Activation of protein kinase C leads to also a number of things, including increased production of VEGF and other growth factors, resulting in angiogenesis and cell growth. Protein kinase C also increases production of endothelin, which stimulates platelet aggregation. Protein kinase C also results in increase in nuclear factor kappa B within the cell. Nuclear factor kappa B is an inflammatory transcription factor that promotes the inflammatory process. The end result include increased expression of receptors for inflammatory cells, as well as increasing the vascular permeability through stimulating cytokine production. Essentially, the increase in vascular permeability and receptor expression allows monocytes circulating the blood to pass through the endothelial layer and enter the tunica intima. The increase in vascular permeability also allows LDLs to pass through. LDLs are low-density lipoproteins. So now we have LDLs within the tunica intima and monocytes. The monocytes have become macrophages. Monocytes become macrophages as they enter the tissue. What happens next is what we see in atherosclerosis. The macrophages engulfs the LDL, becoming what is known as a foam cell. During this process, the macrophage and foam cell release inflammatory cytokines such as TNF-alpha, interleukin-1, which causes further inflammation. The foam cells also secrete some growth factors causing smooth muscle proliferation and migration into the tunica intima. The foam cells, which contain a lot of lipids, eventually cluster together and rupture within the tunica intima. The lipids are released, inflammatory cytokines are released, and growth factors within the foam cells are released when the cell ruptures. And this all essentially will create a plaque. This whole process we just saw right from the beginning, from reactive oxygen species, protein kinase C, to foam cells, all are what lead to the vascular changes. The vascular changes are, there's increase in metabolic toxins. The vascular changes are, we see an increase in metabolic toxins and also atherothrombosis. So to summarize the whole process, starting from diabetes, so we have genetics and obesity and other risk factors. Increase in age leads to insulin resistance. Insulin resistance leads to the beta cell failure. The beta cell failure with impaired glucose tolerance leads to insulin deficiency. Insulin deficiency results in hyperglycemia or high blood glucose. With high blood glucose, the glucose enters the endothelial cells of the vessels, resulting in the formation of or stimulating the function of protein kinase C, reactive oxygen species, AGP, and VEGF, and other growth factors. All this causes toxic diabetic metabolism, endothelial dysfunction, and vascular inflammation. This also leads to atherothrombosis. Together, they eventually lead to the microvascular and macrovascular changes we see in diabetes, which, if you remember, microvascular include retinopathy, neuropathy, and nephropathy. Macrovascular changes include cardiovascular, coronary heart disease, cerebrovascular disease, and peripheral vascular complications. A note to make is that insulin deficiency can lead to some serious outcomes, and these include diabetic ketoacidosis, a hyperosmolar state, as well as a hyperglycemic state. Now, all these are different, however, they're interconnected. So diabetic ketoacidosis occurs because insulin doesn't work, and because of that, fatty acids are broken down and ketone bodies are released into the blood, increasing the acidity of the blood. In the hyperosmolar state, what happens is that because you have so much glucose in the blood, it gets urinated out and thus dragging water with it. And this leads to an hyperosmolar state, essentially a dehydrated state. And then you have the hyperglycemic state, which is essentially high blood glucose levels in the blood. So I hope you enjoyed this video on diabetes, as well as the pathophysiology of the complications associated with diabetes.
Diabetic peripheral arterial disease, PAD, is an occlusive arterial disease affecting distal vessels below the knee. The pathophysiology of PAD can be attributed to structural and functional atherogenic changes to the vasculature. Diabetes augments the process of atherosclerosis by a variety of mechanisms. Two key components in diabetes, hyperglycemia and insulin resistance, contribute to endothelial dysfunction by decreasing nitric oxide bioavailability and altering the function of various cell mediators. Oxidative stress subsequently promotes the formation of foam cells and fatty streaks. In addition, vascular smooth muscle cells exhibit enhanced migration to newly formed lesions, further augmenting plaque development. In advanced atherosclerosis, patients with diabetes have less smooth muscle in the lesions and are more susceptible to plaque rupture compared with the early stages of atherosclerosis. Furthermore, increased platelet aggregation and impaired fibrinolysis also increase the risk of thrombosis, leaving the patient at high risk for complications. Failure to identify and prevent PAD at an early stage can ultimately result in symptoms of intermittent claudication, critical limb ischemia, and lower extremity amputation.
A common complication caused by prolonged high blood glucose levels is nerve damage, known as diabetic neuropathy. Nerves are found throughout your body. They are responsible for everything you feel, from warmth and cold to pain. They also play a vital role in controlling your heart rate, digestive system, bladder control, and sexual function. Small blood vessels provide nerves with nutrients and oxygen required to survive and function. Your nerves are extremely sensitive to any change in their oxygen and nutrient supply. Damage to these small blood vessels occurs when blood, containing high levels of glucose, travels through them on its way to feed your nerves. When the small blood vessels are damaged, a sufficient supply of nutrients and oxygen no longer reaches the nerve, causing the nerve to become damaged and eventually die. The first sign of nerve damage occurs in the feet. It might feel like numbness, tingling, or burning. If left untreated, it can lead to complete loss of feeling and spread to other parts of the body. The area of the body most often affected by nerve damage is the feet. Small injuries such as a blister can be undetected due to loss of feeling. Left untreated, these injuries can become infected and, in severe cases, require amputation. To prevent injuries from progressing, it is important to conduct regular foot exams. This will not require much time and will help injuries from becoming serious.
Lanjut ke pencegahan. Untuk pencegahan atau penundaan diabetes, yaitu dengan memodifikasi gaya hidup atau lifestyle. Studi penelitian telah menemukan bahwa perubahan gaya hidup dapat mencegah atau menunda timbulnya DM tipe 2. Selanjutnya, orang yang mengalami gangguan toleransi glukosa atau orang yang mengalami prediabetes ini beresiko tinggi untuk terjadi diabetes. Kemudian untuk gaya hidup termasuk diet dan aktivitas fisik ini sangat penting untuk mengurangi resiko diabetes. Ini biasanya seperti berjalan sekitar 2,5 jam setiap minggunya. Kemudian dari pencegahannya lain seperti obat-obatan, bahwa obat telah berhasil mencegah diabetes dengan beberapa kelompok populasi. Beberapa obat seperti metformin. Dalam program pencegahan diabetes, orang yang diobati dengan metformin itu mengurangi resiko terkena diabetes sebesar 31% selama 3 tahun. Untuk manajemen diabetes mellitus, komponen utama untuk treatment diabetes adalah yang pertama yang sudah kita sebutkan adalah diet dan aktivitas. Kemudian ada terapi oral hipoglikemi, ada terapi insulin. Ya, itu saja untuk penjelasan kali ini. Untuk tugas yang berikutnya adalah selain dari silakan mencari apa itu lada dan apa itu modi, yang kedua adalah silakan mencari apa perbedaan antara DM tipe 1 dengan DM tipe 2. Sekian dulu perkuliahan kali ini, semoga bermanfaat. Jangan lupa untuk tugasnya silahkan nanti di upload di Skalsa atau bisa dikumpul di meja saya. Saya akhiri. Assalamualaikum warahmatullahi wabarakatuh.